So I want to thank, first of all, funding agencies, donors, and also gratitude to the University of Florida and Public Health and Health Professions for having me here. All right, this is a translational story. First off, I want us to think about all of the patients and parents or our older parent that we've thought of who may have elected to have a total knee replacement surgery or some other surgery, right? They go through the surgery just fine, but then post-operatively, maybe they experience a little bit of confusion. Maybe they experience some issues with short-term memory functioning. And then possibly later on, they are diagnosed with a dementia. And so now what happens? Family members may really harken back and say, okay, well, perhaps it was that surgery. And you know what? I really think it was the anesthesia. And what we've known now is what we're learning, that there's a whole host of other reasons perhaps that are playing a role. Research actually is now showing us that the brains do change. Yes, they change with surgery and anesthesia. What I'm going to show you here is an aggregate of individuals who were seen 1 week before their surgery, before they had an elective total knee replacement surgery. These are individuals age 60 or older who had the same surgery with the same anesthesiology protocol and with the same surgeon. And what you can see here is that there are certain hubs in the brain here that are showing activity and communication together, and the communication strength is depicted by the strength of those lines. Now, within 2 days after surgery, what do we see? We see that the brain has actually changed. Now we see that there is some weakness in some of the connection between certain brain areas, and that's okay. We want the brain to respond, right? It's supposed to have a reaction, but there are certain hubs in the brain that seem to take a bigger hit. And what we find is that there are individuals who actually seem to be more prone to having that hit than others, and so that's a concern. Research also shows us that there are areas in the brain that may predict if you're going to have intraoperative response differences during a time, perhaps, of a total knee replacement surgery. Take this individual here. This is the brain, a sagittal slice. And these are markers, common markers of disease and neurodegenerative disorder. This is one. This is the entorhinal cortex. It's specifically needed for memory function. This is also the lateral ventricular area here. It's quite large for this individual. And then there are markers of small vessel vascular disease, which is commonly associated with hypertension or high cholesterol. All right, now for this individual, and we did this study, it shows that this individual had a lot of busyness during the time of their surgical procedure as measured by an electrical encephalogram. So this is a derived EEG score. And what we know is that these brain disease burden markers explain a lot of the busyness and whether or not an individual will actually need a propofol bolus so that it will keep that individual at an appropriate sedation level for a comfortable surgical procedure. Now, researchers have also shown that the variability that you can have within this EEG will actually predict outcomes such as delirium and even mortality. Research also shows us that post-operatively, you can have an increase in tau, which is a biomarker associated with dementia. And some individuals, well, a lot of us, will also experience an increase in neurofilament, which is a marker of trauma. Well, great. None of us are going to have surgeries now, are we? All right, but the issue that I want to tell you is that there are some things that we can do. All right, so one thing to consider here is you could ask, well, what do we need to do? Do we need to have expensive brain MRIs for everybody? Do we need to have expensive biomarkers? And I'll argue no. Let's take a step back. Let's remember that we have professionals who are actually attuned to brain function, all right? And that can provide some insight onto elements of cognition. Because remember, what does the brain do? The brain is responsible for behavior. It takes information from your environment, it incorporates it, and allows you to act on things. It is your organ of behavior. So let's assess behavior. Let's identify who is vulnerable, perhaps prior to surgery. Let's use things such as the following. If I asked you to draw the face of a clock, put in all the numbers, and set the hands for 10 after 11, well, I could actually do quite a pretty good job of assessing how you're doing from a memory and thinking standpoint. I could assess your processing speed. As you can see, this gentleman's a bit slow. Some organizational issues, your planning, your visual spatial function. I could do a pretty good job of getting a snapshot, some sort of glimmer into your actual brain function or your vulnerability. All right, so that's great, all right? You can look at this and see some issues. Now, what if I said that we could actually put this type of rapid screening tool that takes about 2 minutes and we could put it into a preoperative center? Well, we did that, and what we found through observation was pretty shocking. We found that there's a whole host of individuals, and through this snapshot, we could start to see different levels of impairment. Now, as a neuropsychologist, I'm trained on behavior, brain behavior, that's what we do. So it's pretty easy for me to understand that certain clocks and certain behaviors are identified here. So we can see vulnerability. And this is vulnerability that we can actually see in an individual that I'm going to show you now. This is an individual who is in his 70s who decided that he needed to have a meningioma removed. All right, so I say he decided that he needed to. He chose to have a surgery. The surgeon actually did not want him to have the procedure, didn't feel that it was necessary, but the family felt that it was important for him to have this meningioma removed because he had some elements of dysexecutive behaviors. He was having some personality changes, becoming a little bit more impulsive. So they thought that, aha, this meningioma must be playing a role in that. So he actually, I have a clock from him, pre-op. Here's his clock. You can say, okay, there's something going on with him. All right, he did have the surgery. He went through, had the surgical procedure, and then he was fine. He went home. Once he got home, he started to have some issues with confusion. He started to have issues such that he became more combative. He was abusive to his wife. He was having marked delusional episodes. We brought him back once he was stable, and now you can see that postoperatively he had a marked change. Now, you're not a trained neuropsychologist, but you know that that is odd, right? There's a change in his behavior pre to post surgery. And then I'm going to show you even further when we get him in for care, you can see that now he actually had a positron emission tomography scan showing that he had frontotemporal dementia. Now, if we harken back to the research that I told you earlier, now you can surmise that, aha, perhaps he went through some surgical stress and the pathology is actually accelerated, and now the surgery has unmasked what was there before, which he had frontotemporal dementia all along. It's just moved it and accelerated it along. Now, this is a public health issue. This is why I'm here in the College of Public Health and Health Professions. We have gaps in our care, specifically in our preoperative care. All right, let me tell you, in Florida, did you know that we've had a 20% increase in Alzheimer's disease since 2020? And did you know that in the community, at least 1 in 5 individuals have an undiagnosed dementia? And where are these individuals going when they need help or when they choose to have surgery? And let me tell you and remind you that the majority of patients who are coming into the hospital for surgery are older, age 65 or older, needing or electing surgical procedures. Well, within Gainesville, they're often going to come to UF Health or North Florida, and so that's great, but here's the problem. Only 2% through our research show have any diagnostic code of any type of impairment in their medical charts. Now, that's a major problem. Why is that a problem? Because anesthesiologists and surgeons, if it's not in the chart, they will not know. They do not know if their patient has a vulnerable brain. And that is a concern. They can't change the anesthetic approach. They cannot change the care for those patients. They can't add additional delirium screening. They may not ask for a geriatrician follow-up. They may not ask for additional day stay. So now we have a problem. All right, this is a problem for many reasons. Did you know that even for simple procedures like colonoscopy, preoperative brain issues, subtle issues, even with memory, undiagnosed cognitive issue, a problem with such things as colonoscopy, bowel prep, and the list goes on, okay? So it's also a concern because of the fact that we know that there are so many different risk factors. We're researchers. We know the risk factors for delirium. We've published over and over and over about the risk factors for delirium and postoperative. But there's an issue here. I'm going to argue that we have cardio clearance routinely for anybody who comes in for surgery. Why don't we have neuro clearance? What is going on here? All right, surgery is a brain stress test. Why are we not paying attention to surgical procedures and brain health, particularly for our older adults. And you could argue even this for peds for different reasons. Now, let me tell you that we have the Perioperative Cognitive Anesthesia Network. That's what we've designed. We designed this with colleagues here within the college because of the research that I'm showing you here. Let me tell you how it works. It works in a series of stages. And what we do first is we do pay attention to brain health. We try to for people who are over the age of 65. Individuals who are over the age of 65, they actually come through the hospital here within UF Health, and they're given a clock test, akin to getting an EKG or an electrocardiogram. If that clock test is abnormal in any way, they also get education and 3-word recall. If it's atypical, then they let us know. They come to see a specialist, not a cardiologist. They come to see a neuropsychologist or a behavioral neurologist. And I can tell you that I'm a lot cheaper than a cardiologist. I'm pretty down on the low totem pole, but I spend a nice amount of time with patients, and we discuss a lot of things. We go over the risk factors for delirium. We talk about depression, all the different risk factors for cognitive issues. And then what happens is a note is sent to the surgery team, and then at that time, they can make changes that they need, and a diagnosis goes in the chart as well if need be, and I follow up with the primary care. That accelerates care with geriatric medicine that can then follow back on these 2 phases, which had a baseline. And then we can have follow-up care with a specialist, such as a behavioral neurologist, who can do follow-up and accelerate care, for example, like that FTD patient. And this is just a shout out to some of the team members here, okay? So do we make an impact? Does this make an impact when we've made a change like this? Yes, it has, all right? And our goal is to be of value, but value particularly to the patients and to the surgical team so that we can have better outcome. The outcome that we've seen with impact has been published in case reports, cohort studies, and patient ratings. It's mostly the patient ratings that I love because we followed patients, they finished anonymous feedback cards. We had more than a 50% response rate, showing how they appreciated attention to brain wellness and that they considered it improved the confidence in their surgery team and their care planning. Additionally, this type of program is nice because it's interactive. It's interactive across different professionals, and I can tell you that medical students, anesthesiology residents, and surgeons have very little information and understanding of neurodegenerative disorders. So as part of this perioperative team, they get training in that, and that increases their training satisfaction. It's also wonderful because through this pathway, what have we done? We've funneled now all of the older adults who have come into the surgical centers. We can identify vulnerability. That's wonderful for lots of reasons for the patient, but also for junior faculty who are interested in this topic and want to develop resources and training issues for improved care, but also clinical trials, different types of interventions. So what's the next phase of growth? Growth, next steps, impact. We want to continue impact. And one thing that we're pushing in 2 weeks, we're actually leading the development of guidelines for perioperative care for dementia. Did you know that Alzheimer's disease, a majority of individuals who are coming through, they may have an infusion therapy, but anesthesiologists and surgeons don't know how to handle infusion therapy, so there's a need for guidelines for this. Other things, we need to increase UF as an age-friendly hospital. We have very few outcome with regard to delirium in the hospital. We need to improve that. We need to improve our training, interdisciplinary. Economics is a big one. The value of having a neuropsychologist and the value of having a team-oriented approach, of paying attention to brain health. And then finally, we need to have improved research so that our parents, when they choose to have a knee or a hip replacement surgery, they can enjoy that new knee without complications or worry of cognitive function. Thank you.